when you talk about cerumen infections, but specifically if it's insects, if it's jelly beans, if it's small things that children are putting in their ear. Children are more commonly, more likely to be diagnosed with the foreign body. Also hearing aids batteries from the hearing aid. So remember, like, that portion of the hearing aid is inserted into the external auditory canal, so that can dislodge and be located in the EAC accidentally. Symptoms of foreign bodies may include ear pain, pruritus, clicking, popping, tinnitus. It can be confused with tinnitus or tinnitus. Also, the patient may have some conductive hearing loss, because remember, we're in that external auditory canal. We're having some blockage there. So doing your Weber and Renee test may be positive for conductive hearing loss. On physical exam, so we perform our otoscopic exam, and we might see a foreign body within the ear. Also, signs of middle ear or inner ear symptoms. So even though we're talking about foreign bodies in the external ear, they could have some pathology going on in the middle or inner ear. Signs of that may be dizziness, vertigo, or sensory neural hearing loss. Treatment for foreign bodies. So we're going to remove the foreign body. We can use these loop or hook removal devices. Again, it is a risk of perforation, right? So we need to be careful of removing it. They also have little forceps that you can use to remove the foreign body as well. Careful not to push the foreign body closer to the TM, because at that point we might not be able to treat it. We might have to send it off to ENT if it becomes too difficult. But we can at least try to remove the item. So reasons for us not to use irrigation. In my experience, I typically use irrigation, or my medics will. It's been a few times where I've used a hook or a loop device, but it's really hard to kind of see in that external auditory canal. One of the students, they were showing me, I guess it was like a removal device. It had a little camera on it. You could buy it from like Amazon or something. Me personally, I haven't used those devices. I didn't spend like my personal money on those devices as well, because the Army typically won't issue you those. They have issued us like ultrasounds, but to get the funding for that is pretty expensive. So I've used irrigation. Biggest thing is if the patient has organic material, so if it's an insect, if it's a jelly bean, if it's a bean, we do not want to use irrigation, because that item can swell and it'll just worsen the obstruction, and again, we'll have to refer them out to ENT to remove it. Other reasons why we would, so that's organic, and then no lidocaine. So lidocaine is also ototoxic. So if the patient has perforation, we do not want to anesthetize the foreign body if it's an insect, right? So ideally we would, but we need to confirm that the patient does not have a TM perforation. Now, how can we confirm that the patient does not have a TM perforation? What was that? HPI. So what in the HPI are we looking for? Yep, any history of trauma, skydiving, scuba diving. Also, sometimes the foreign body may not completely obstruct the external auditory canal, so we might be able to see beyond it as well. I'll show you a picture here in a second where you'll see an insect that's actually dislodged in the external auditory canal. We can use mineral oil. That just creates a more like a moist environment to help remove that item. But the biggest thing here is no lidocaine if they have a TM perforation, because ototoxicity is essentially hearing loss, permanent hearing loss. That's why I keep saying that. So that's why we do not want to use lidocaine. Referral process. So if anesthesia is required, if we have a child that's not cooperating, if it's just difficult to remove and it's out of your scope, those are reasons that we can refer to ENT. Now, getting into otitis externa. Again, we kind of talked about some of this already, but it's 3 stages. So the first, the pre-inflammatory stage. So that's where basically the environment is being created to manifest into otitis externa. So maceration, the EAC is too moist. The good bacteria is being washed away. Maybe the cerumen is not, they don't have enough of the cerumen, because remember it has those protective factors, it's hydrophobic, right? And then it has the antibacterial effect as well. And then also occlusion of those sebaceous units. So the sebaceous units create the cerumen, so if they cannot create cerumen to provide those functions, that could all lead to, that's all pre-inflammatory stage, leading to otitis externa. And then we get into the inflammatory stage, so that's where bacterial growth occurs, worsening edema, increasing pain, and then chronic. So chronic is essentially the inflammatory stage, but just when the patient has it beyond 3 months, 3 months or greater. So causes of otitis externa, water exposure, because remember that maceration, it allows bacteria to be harbored and fester into the EAC. Extensive scratching of the EAC with cotton tip applicators, bobby pins, what have you, because we can create breakage of that epithelium where bacteria can fester and harbor. Most common organism is that Pseudomonas aeruginosa and also Staph aureus as well. Symptoms of otitis externa include pain in the ear, pruritus, discharge. It can be purulent, it can be clear, it can be murky, or just a sensation of oral fullness, so ear fullness. These are signs and symptoms or physical exam findings of advanced disease. Biggest thing here, so distinguishing from, is this patient in an advanced disease stage of otitis externa? So drainage, like is it purulent? Have they developed conductive hearing loss? Because remember, we're in the EAC, that blockage, that edema can cause obstruction. When manipulating the ear, is it painful? And then, can you even see the TM like that? Or is it too painful to insert that otoscopic tool to try to visualize a TM? So those are like degrees of how you can tell, oh, this patient may have advanced into advanced disease. So severe disease, so we kind of talked about this yesterday as well. So auricular cellulitis, perichondritis, and chondritis. We really can't distinguish between perichondritis and chondritis. The biggest thing is to be able to distinguish between auricular cellulitis and chondritis, because if it's cellulitis, it's gonna involve that auricle lobe, so down here, because that's where there's no cartilage in the lobe, the ear lobe. Symptomatic treatment, so we do want to treat the patient's symptoms because this is going to be extremely painful depending on the advancement of their disease. So we can prescribe NSAIDs or topical steroids in conjunction with treating the actual infection. So uncomplicated OE, so this is for a patient that presents to you with 7 days or less, right? Uncomplicated to clarify is no comorbidity, so they don't have a history of like diabetes, COPD, stroke, hypertension. Those are all comorbidities, right? Or signs of advanced or severe infection, like what we just talked about. So in your HPI, you have to be able to identify, like, does the patient have erythema, or do they have hearing loss? Do they have some purulent discharge, and kind of connect those signs, symptoms, physical exam to get to your treatment. So primary treatment for uncomplicated OE, right? Uncomplicated OE, we can start with a drying agent. Patients can get these over the counter too. Like, it's so many different like over the counter brands. Depending on your medical treatment facility, they may have them on formulary, they may not. But essentially what it's trying to do is trying to decrease that maceration and get the pH of the EAC back to its normal state, right? So that's the purpose, because it's 50% alcohol, 50% vinegar. And when with maceration, the pH is too alkaline, right? So we're trying to get that acidity back to its normal state. That's the primary treatment. That's something that we can try. Now, excuse me. for complicated OE or uncomplicated OE refractory. So uncomplicated OE that's refractory to treatment. So we've tried the drying agent, but it's not working. So then we progress to the next step, which is going to be a topical antibiotic. But understand, for complicated OE, the patient may have comorbidities, right, like hypertension, diabetes, or they may have signs of advanced or severe disease. So if a patient has periauricular cellulitis or chondritis, would you classify that as complicated or uncomplicated? That's complicated. So if the patient has complicated OE, our primary treatment is going to be the odic antibiotic drops. So we're not even going to mess around with trying to prescribe them a drying agent because it's not going to be effective. Does that make sense, everybody? Okay. So just make sure you read closely on the patient's signs, symptoms, and physical exam findings. Primary is going to be that fluoroquinolone topical. The aminoglycosides, so like that neomycin, we can use those if the TM is not perforated because that is ototoxic, and we know that we don't want to cause the patient hearing loss. So stay away from neomycin if the TM is perforated. This is a good highlight. So it is some combination treatments, like they have the antibacterial effect and they have a topical steroid as well to help with the patient's swelling, pain, and the actually treating the bacterial infection. So those are available in so many different combinations. It's really just going to depend on which your MTF has on formulary. Okay, so yes, sir.
So, normally steroids are not used for bacterial infection because, yes, it's being used in but also not really being used as a counter.
Mm-hmm.
So why are we using steroids?
It's to help with the swelling.
Right.
You can use it. Primary, I would probably typically use like an ofloxacin, topical fluoroquinolone. You can use it. They do have the combination. So it's going to depend on your practice, how the patient is presenting, if they even have enough swelling to where you want to add a steroid. So all of that is going to be dependent on your practice. So with using the topical fluoroquinolones, patient education is going to be so important with these treatments and diagnoses. So typically for me, I will place the first earwick for the patient, right? Because what you don't want is to send the patient home with an earwick. They saturate the earwick and then try to push it into their ear. That's not what you want. Because then it may not completely treat the EAC because it's not going to get down into that infection and saturate where the bacteria is located. So ideally, I will place the earwick in the patient's EAC, saturate it for them, and if they do need a repeat use of this earwick, that way they have that experience, that exposure to how to replace another earwick. Usually you can saturate it with like 4 or 5 drops. It's not like, oh, you have to do 4 drops or 5 drops. Just making sure that it's fully saturated, so that way it's going to cover the EAC and treat that epithelium, that squamous epithelium. Let's see. All right, so treatment for complicated OE, so severe disease, perichondritis, chondritis, auricular cellulitis. So if disease extends beyond the EAC, that's how we know it's severe in our physical exam, right? We have to go directly to start oral antibiotics, again, fluoroquinolone, because it's going to penetrate bacteria that's in the cartilage, also in that squamous epithelium. So that's going to be our primary treatment. So complications of otitis externa, and we'll talk about this a little bit later. So malignant otitis externa. Sorry about that. So malignant otitis externa is a complication of otitis externa, usually secondary to untreated OE, right? So it's a sequela, it's progressing, or the patient might have some comorbidities that that lead to them to being more susceptible to malignant OE. Referral, if need be, so if the patient is refractory, you try the drying agent, you try the topical antibiotics, you try oral antibiotics. Ideally for chondritis, perichondritis, we treat with oral antibiotics, but we're gonna refer them out to ENT. Remember what we talked about yesterday? So if the patient presents to you with perichondritis or chondritis, we start oral antibiotics and refer them out to ENT. And then other reasons would be for chronic OE. So you've been trying to treat this patient with the drying agent, topical antibiotics, maybe oral antibiotics, and it's not resolving, so we need to refer them out to ENT. All right, so fungal otomycosis. This is about 10% of total OE infections, right? So just kind of developing our differential diagnosis when a patient presents. Symptoms, they do present very similarly to bacterial OE. One of the things that can help us determine whether or not it's otomycosis is if the patient's symptoms do not resolve with treatment of an antibiotic. That's one of them, but we have to put the clinical picture together because that alone is not going to tell you that it's otomycosis. The most common organisms is the Aspergillus and the Candida. That's yeast. Pathogenesis is the same, that pre-inflammatory stage to the inflammatory stage, and then it can develop into the chronic stage if it's over 3 months. So high-risk patients include diabetics, immunocompromised individuals, or individuals that have had the mastoidectomy. So removing that, remember how close the mastoid is in relation to the EAC. So removing that mastoid and opening up another space for moisture for bacteria to harbor infection, in this case fungi, and it can lead to otomycosis. So this is our bread and butter of determining if it's otomycosis or if it's otitis externa. So putting together the patient's signs, symptoms, and then physical exam. So because discharge, like it can be discharge, but is it from fungal? Is it from bacterial, right? So conductive hearing loss, okay, that can be in fungal or bacterial otitis externa. That can be associated with a bunch of different things, but specifically, if we see that mycelia in the EAC, so doing our exam, or if we see that fungal debris, that gray, white, black matter, those hyphae, this could clue us in more that the patient may have otomycosis versus acute bacterial, acute external otitis. Also other things like, it's going to be inflamed. The patient may have some pain, the patient may have some discomfort. So it's going to present very similarly, but physical exam findings helps us clues us in on our diagnosis. Other things that we can do, and this is going to depend on your clinical setting, whether you're in the ER, whether you're in a family medicine clinic setting, we can do a KOH wet prep in a fungal culture. Ideally, a culture needs to be sent out to the lab and then received later. But if you are trained to do a KOH wet prep, you can just collect a quick sample, place it on a slide, apply the KOH, and then help either one or two things. If you're not trained to do this, just get with the lab and ask them to help you read that slide because it will show hyphae under the microscope. So you do need to be trained to do this, but this is a tool that we can do in-house in clinic to confirm otomycosis. Additional treatment includes cleaning and debridement of the EAC. We could do that with those loop removal devices. Again, if you have the experience to do that, I've seen some of my colleagues do it with irrigation as well, but a lot of times this debris is so thickened and hardened that irrigation may not help, or you might not be able to remove all of the fungal infection, so we need to treat them with a topical antifungal in addition to the debridement. All right, so getting into necrotizing malignant otitis externa. Also known as skull-base osteomyelitis. All right, so this is osteomyelitis of the temporal bone. So just kind of going back to our anatomy, right? So the skull and the temporal bone, like how closely related it is to the EAC, right? So this is chronic. This is a complication of otitis externa. So potentially untreated otitis externa, or if the patients had some risk factors like that causes them to be immunocompromised, diabetes, maybe they're a cancer patient, HIV/AIDS, those kind of things can lead them to necrotizing otitis externa. Most common organism is going to be that Pseudomonas aeruginosa. So the pathogenesis of OE, so chronic OE, soft tissue infection, we kind of went through this already, pre-inflammatory, inflammatory, and then chronic. And then it can develop into that cellulitis, or that pre-auricular cellulitis, going into either perichondritis or chondritis, so you can kind of see how it's sequelas. Osteitis, where the periosteum of the bone is infected, and then developing it into the osteomyelitis, that's where the bone marrow is infected. So all a sequela. It can spread to the Haverson's canal. So that canal, if you remember, it harvests nerves, blood vessels, and also like some blood vessels, nerves, and veins in there. So understanding that, compromising that, they can develop some type of palsy, which we'll talk about here shortly. Elderly and diabetics. So again, these patients may be immunocompromised, so their immune system is blunted. They cannot heal like a patient that has a normal immune system, because that neovascular regeneration is not to its superior, is not able to regenerate like it's supposed to. And then also, so elderly have more alkaline cerumen, right? So remember how we talked about the importance of the acidity component of cerumen? We don't want the EAC to be extremely alkaline, because then that could lead to infection, maceration, otitis externa, and then developing into malignant otitis externa. Signs and symptoms. So some symptoms that specifically stand out are long-standing ear pain or otalgia, or if it's worse at night. Their discharge may be particularly foul. They may it may be very descriptive, like it smells like trash or garbage, like as opposed to if it's just acute otitis externa, it might just be purulent discharge, right? So it'll be a very descriptive, very discrete type of discharge. Smell. On physical exam findings, we may see some granulations on the EAC, right? Because remember, these patients may be immunocompromised, so those blood vessels cannot regenerate, they cannot heal as well, so we may see some granulations there, either on the EAC, in the EAC, or on the auricle. Again, that foul oral discharge, and then advanced disease could be a palsy, so the weakening of nerves innervating the muscle. So you guys will learn more about like facial nerve palsy, Bell's palsy, but the nerves that are innervating certain muscles are not able to perform those actions, and it leads to defects. So for Bell's palsy, you may see like an eyelid just closed, or they may have some asymmetry in the face. That's why we do our cranial nerve exam. Other physical exam findings, so edema, periauricular lymphadenopathy, trismus, so difficulty opening and closing their jaw. So the only symptom may be pain out of proportion with the exam. This is not common. right? It can present that way, but generally, you're gonna have a good medical history and a track record of this patient's symptoms to kind of come to this diagnosis. Labs, we can do an ESR or CRP, that erythrocyte sedimentation rate, but these are very non-specific labs. It's just gonna show that it's inflammation within the body. And then just to be more specific, we get a culture and a sensitivity to kind of help the treatment for this diagnosis. But again, that's gonna take some time. Usually in clinic, maybe like 2 to 3 days, depending on the lab, I mean, up to 5 days. For imaging considerations, so remember, necrotizing otitis externa, we're talking about infection of the bone, so the temporal bone, osteomyelitis, osteitis, so in that area, so we want to get a CT initially. Also, a CT is going to come back a lot quicker than an MRI. So we can diagnose or determine like the extent of the bone that's infected. And then we can progress to an MRI if necessary, right? But the initial study is going to be the CT. That gadolinium scanning, that's used to track progression of patients that have necrotizing otitis otitis externa. But usually that's going to be seen like inpatient, right? Because they're going to these are like severely ill patients that they want to track the progression of their disease. So that's not something that we commonly use at the primary care level. So treatment, initially we're gonna start with IV antibiotics because these patients are gonna be admitted, right? We're not going to diagnose malignant otitis externa and discharge a patient. We'll get ENT involved, depending on your setting, you might be in the ER, or we might refer them over to the ER from the clinic, right? So we can expedite their treatment. But the point is, these patients should be admitted and started on IV antibiotics. We can use either of these antibiotics to start with because they have broad coverage, and then based on the culture and sensitivity, they can tweak the antibiotic once they determine what organism is primarily causing it. After discharge, they will be started on oral antibiotics between 6 weeks, and based on their progression, it could be 6 weeks, it could be a couple of months, which is not conducive to these patients because they're already immunocompromised, right? And we know antibiotics can kind of throw off our natural flora. So it's kind of like a double-edged sword, but we have to treat the source. Patients that are refractory to IV or oral antibiotics, we can refer them for a surgical debridement. Again, remember, if a patient is refractory to IV antibiotics, they're going to be admitted, right? So they're already in the ER, they're already in that setting, so we just kind of get ENT involved, and they can make the decision on if they need to perform a debridement and actually essentially like remove some of the infected bone to source control. Other considerations are glucose control, manage their immunosuppression, so what is causing them to be suppressed? Is it diabetes? Is it cancer? Is it HIV? So making sure that's managed properly. And then for education on oral hygiene, so usually these patients are going to be tracked by ENT, a specialist, so they probably won't come to you for cleaning. It'll be something more managed by ENT. Complications of necrotizing otitis externa. So just so you understand like the severity of this condition, it can lead to meningitis, so inflammation of the meninges within the brain. Sepsis, so that's where you have essentially a blood infection, like the bloodstream has an infection, or death. So it can sequela into these if we do not treat it. All right, check on learning. If I could get one volunteer to read this question.
A 16-year-old female swimmer presents with pain in her right ear for 3 days. Physical examination reveals a tender, swollen, external auditory canal with purulent discharge. Her tympanic membrane is intact and mobile. Which of the following is most likely causative organism for this patient's condition?
What are we thinking? E, echo, yep. Yeah, perhaps, I mean, this is a 16-year-old female, they have, kind of just walking through it, so adolescent, swimmer, so they have exposure to water, right, frequent water, um, tenderness, swollen, external auditory canal, they have some purulent discharge. Would you classify this as severe or, advanced disease, otitis externa? And why would you classify it as advanced?
Purulent discharge.
Purulent discharge. Yes, very good, very good. We don't have any signs of chondritis or perichondritis, would you say? Correct. Okay. And no history of diabetes, immunocompromised. Well, she doesn't appear immunocompromised. Would you all agree? Probably pretty in shape. Okay. All right, going to pruritus. So, any questions? I kind of like road. Any questions on anything we covered so far? Okay. So going into pruritus, so this is excoriations of the EAC, likely secondary to cotton tip applicator, scratching, or taking a fingernail and scratching, or using some type of foreign body and scratching within the external auditory canal, creating those skin lesions. So thinking about like the pathophysiology as we're breaking the skin, bacteria can get in, harbor, fester, and cause like some of that itching or an infection. Other causes can be psoriasis, so that's where you see patients that have flaking or scaling at the elbows. They have it at the also on the like kneecaps as well. You won't be required to like identify this because you don't get dermatology until you are senior semester, but this is just like purely informative. And then that seborrheic dermatitis. So again, patients may have like flaking, scaling of the skin. They may have dandruff, that kind of thing. Or they might have a past medical history in the vignette with these a past medical history of these diagnoses within the vignette. Symptoms, so pruritus is essentially just itching of the ear. So that's the same thing. If a patient presents with pruritus or they tell you they have itching, those are the same thing. Physical exam, it can be unremarkable, or we can see those excoriations, those skin lesions that have developed from the patient irritating that squamous epithelium in the EAC. Again, those signs of psoriasis or seborrheic dermatitis. Treatment, so primary treatment is to allow the cerumen to regenerate, because ideally thinking about itching or scaling or dryness, so bless you, it's probably, the EAC probably is too dry, right? So if we see some scaling, then we can allow the cerumen to regenerate to perform its normal function, right? We can do that. We want to avoid soap and water, cotton tip applicators, I feel like I've said this a million times, scratching, that kind of thing. We can place like 1 or 2 drops of mineral oil in the patient's ear to give it some of that moisture to help with purely those symptoms of itching. And then if necessary, a topical steroid, but that's like the last resort. Alright, exostosis and osteoma. So both are bony growths within the EAC. Causes, it can be idiopathic, also known as swimmer's ear. So repeated exposures, patients may have repeated exposure to cold water, like frequently swimming, surfer's ear, patients may be asymptomatic, so it could be an incidental finding. It just depends on the patient. They may also have a sensation of oral fullness or that conductive hearing loss. Physical exam, so this picture on my right, I think it's your left or right. So patients, it could be an incidental finding, but this particular picture, the patient likely has like some conductive hearing loss, like some sensation of fullness, because they have multiple osteomas or exostosis within the EAC, completely blocking the EAC. Like we cannot even see the TM. Ideally, so the difference between the exostosis and the osteomas, exostosis is usually they can protrude from like any portion of the ear, and they're usually a little bit more like flat, sessile, whereas the osteomas could be a little bit more pedunculated, so they have that stop. But essentially, they're the same thing, bony protrusions covered by mounds of skin, and they're gonna be located in the EAC. So we have to get, this is a picture of a CT, so to officially diagnose, we have to get a CT. Treatment is gonna depend on the patient, their symptoms, and your consultation with ENT. So do we just observe, is it an incidental finding and the patient is asymptomatic? We probably don't need to do much about it, right? But if the patient is having symptoms, if they have multiple osteomas, then we might wanna refer them to ENT to consider removal. Complications of these diagnoses include obstruction and infection. As you can imagine, EAC is obstructed, conductive hearing loss, infection. It's a bone within the EAC that should not be there, right? So allowing bacteria to harbor and fester. These are different grades of osteomas. You won't be responsible for grading osteomas, but just to kind of give you some examples of severity. Now going into neoplasms of the EAC, so this is not an all-inclusive list, but this is probably like the most ideal for the PANS and what you will see in clinic. So glandular and squamous cell carcinoma is the most common. So glandular and squamous cell carcinoma are the types. Squamous cell carcinoma is the most common neoplasia of the EAC. First, glandular neoplasia. So these are just some subtypes, just kind of being familiar with the nomenclature of adenomas are usually benign as opposed to carcinomas. They have that malignancy, they're more commonly malignant. Symptoms, so again, kind of including some discharge or fullness, pain, hearing loss because we're obstructing the EAC. Physical exam findings, the patients may have a mass, some discharge, otorrhea, conductive hearing loss. Imaging. So just kind of going back, do you all think we can diagnose a glandular neoplasm just based on the symptoms and physical exam findings? What do you think? Yes, we definitely need a biopsy, right? But just looking at the symptoms and the physical exam, like, just put yourself in the clinic, like trying to evaluate. You don't know this diagnosis yet. We have to get some imaging, do some labs, biopsy, etc. But my point is, a lot of these conditions, they present very similarly, so you just have to pick out the differences as to help you with the diagnosis. All right, imaging, so primary, we're gonna start with a CT to assess for the extent of disease to see if it has infected the bone. Also, CTs are, they usually result pretty quickly as opposed to an MRI. And then we can progress to an MRI if necessary to assess the actual lesion, but we have to get a biopsy for a definitive diagnosis. Treatment, we'll refer them to ENT, and they'll make a decision on whether or not they want to do chemotherapy versus surgical excision, etc. So squamous cell carcinoma is the most common neoplasm of the EAC. Again, the symptoms can appear very similarly to glandular neoplasm or an osteoma, or maybe not necessarily, maybe kind of like otitis externa, but really we have to kind of tie in our HPI, our physical exam, and then our lab findings and CT to come to this diagnosis. Physical exam, so one different thing that we might see are those visible ulcerations in the EAC. Where else could we potentially see ulcerations or granulations? What other diagnoses? What was that? Yep, necrotizing otitis externa, or also known as malignant otitis externa. So we can also see like some ulcerations or granulations of EAC. So treatment for squamous cell carcinoma, refer to ENT, they'll make the decision whether or not to do radiation therapy versus excision, in determining their prognosis here. I did wanna add one thing, so same as a glandular neoplasia, we still need to get a biopsy for the definitive diagnosis. So regardless of if it's squamous cell carcinoma, because I don't think the slide really explains that very well. Yeah, because it's only for glandular neoplasia, but we definitely have to get a biopsy to diagnose the patient with squamous cell carcinoma as well. Alright, if I can get a volunteer.
5-year-old male presents with pain in the right ear for about a week. Physical exam, in the ear. Following removal methods is contraindicated as a treatment patient.
What are we thinking? Oh, I didn't hear you. What did we say? C, irrigation. Can anybody tell me why we would not irrigate this 5-year-old male? That doesn't swell up. Perfect. Alright. Let's take a 10-minute break. And then we'll get into probably about half of the next lecture.
Boy, get that X-ray. Get that X-ray. Oh, man, really?
It's like 5 hours, yeah.
Did you get a reading?
No. It's like, you guys see anything like, I guess they're not allowed to say.
Didn't let you look at it? Pull it up. Hey. PAS. You gotta name this.
But no.
You know why they're going down, right?
Well, yeah. No, I mean like originally the new ones are like yeah. No.
I was like, you're sure about
Oh no. I was like no. It was because it's a premium plus for training. No.
they're only taking 1,000.
No, man, no. They just so everything I think like the final price is gonna be like
Those with the taxes.
yeah, I make sure.
That's why I say taxes.
Oh, they.
I told you.
I don't know that you can take off the taxes.
Yeah, I said like 5.
It sounds good. Are you talking about with the taxes?
Yeah, that's what I tell
Oh,
them.
yeah.
They do the math after that.
Well, they gave me the breakdown, so that's why I had to separate stuff. But it's set because usually they have.
Wait, you guys didn't turn in your essays. You're like, okay, I'll just write it.
Wait, $30? Were you with your Yeah. He's like, he's like, I don't take that. $30. That's all it's like. There's yeah, but it's still, if someone's on me right there, I'm not gonna.
No, but at the same time, like, why the fuck are you paying attention? Since they're selling it to you, they should teach you.
I say tips.
They did a vanity. That's what happened.
Yeah, it sounds like I'm.
That's all I know.
I should have seen it.
You pay us with our
You can pay me 15, I would.
He said, dude, there's a counter, he said, give me cash.
I'll take down.
You pay me. What was this? State or DC?
It makes it worse.
What's a long time ago? Oh, Lord.
I never remember that. You have to pay someone to show you how to use your arms. Dude, do that automatically. That should be part of their selling criteria. By like, oh, you can
Also,
do
just press a button.
yeah, literally, I got all that information.
Has like, something called.
What is it? It was a Kia. And Kia charged you 30. How did the Kia charge you 30? I think the guy just bought it. It's all cars. It's still.
Good.
Well, it sounds like that guy.
Good. That's good. That could be a side hustle.
The fake ass shirt. Like, I work here.
It's crazy when you see people like that. That was on my side. That's my We're still lawyers. At least
Maybe you can easily like cheat away the ball.
hey, as long as you get with the law and give me out of fun. They got me out of a reckless driving. I was running like 90 on the 70. Apparently that's not Trump. It's really big. So I was
They all work like that. Here's the thing, they can't call
All right, let's take your seats. You in the back, do you guys hear me?
Sure.
Okay. All right, so we just finished up the external diseases of the external ear. We went through 1 and 2. Now we're going to move into pathology and diseases of the middle ear. This is our core terminal objective, and then these are our enabling learning objectives. All right, so just kind of going over some anatomy initially. So key anatomy here is going to be that pars flaccida. You can see the short process of the malleus here. But key thing, looking for retraction pockets, right? Discoloration, any lesions, is it perforated? Also identifying that cone of light. Also, I think you might hear it frequently, like the reflex light, or is present. I forget the exact terminology on you guys' practicums. All right, so getting into eustachian tube dysfunction and auditory eustachian tube dysfunction as well. Here, just kind of highlighted, you can see how horizontal the baby's eustachian tube is as compared to the adult, where it starts to kind of form that S shape that's more protective, preventing like bacteria to harbor. This is just some information regarding the length of the eustachian tube, so about 35 millimeters long. But just understanding the function of the eustachian tube. So primary functions are to equalize the pressure through opening, closing, yawning. Also mucus drainage, so it doesn't build up and an infection doesn't occur. All right, these are just pictures of the right eustachian tube orifice. So at rest, it's naturally going to be closed, whereas when a patient is opening, is yawning or swallowing, it's going to open. You can see that on I think it's your left or my right. All right, so two primary types of eustachian tube dysfunction, so patulous or dilatory. We'll go over both. If we are referring to eustachian tube dysfunction, we're primarily referring to dilatory. So first, patulous. So this is a dysfunction where the eustachian tube normally. So just think about its function. So it normally balances the pressure, drains mucus, but it's patulous, so it's open. It doesn't close. It has like an opening. This can be caused to rapid weight loss. It can be a neuromuscular disorder, or it can be idiopathic. Symptoms. So one thing that sticks out here is that autophony. So patients may tell you like, oh, it sounds like I can hear my voice, or an echoing. Also, if a patient specifically identifies exercises or the performance of exercise that makes it worse, because when exercising, ideally our blood vessels vasoconstrict, so it's making the eustachian tube a little bit more open. So their symptoms are going to be worsened, as opposed to if they have an upper respiratory tract infection, then it's going to be swelling in the eustachian tube, so it's going to close up that area and allow for it to function normally. For physical exam, it could be normal. TM may move, but it's really going to be an association and correlation of the HPI and physical exam for this diagnosis. So for treatment, we want to avoid decongestants because what's going to happen with decongestants is it's going to decrease the swelling within the eustachian tube, so it's going to make that area, that orifice more open. Patients can get ventilation tubes. We'll refer them out to ENT for that or for surgery. Now going into eustachian tube dysfunction or dilatory eustachian tube dysfunction, pathogenesis, so the eustachian tube does not open properly. So remember, that's one of its normal functions is to open and close and equalize that pressure. So negative pressure builds up in within the EAC. Most common cause diseases causing edema of the tubule ligation, so upper respiratory tract infection, allergies, chemical irritants, even pregnancy. Symptoms: a patient may have some oral fullness, or they remember that, or they may have like some conductive hearing loss. That's also, I don't think that's on here, but that could be associated. Fluctuating hearing, conductive hearing loss. Discomfort with barometric pressure change, so are they skydiving, air diving, or just are they getting in the airplane and traveling? Patient may report some popping, cracking when yawning or swallowing specifically, so not tinnitus, but specifically with yawning or swallowing. And then physical exam findings. So here you can see the normal TM, and then at the bottom it's a retracted TM. You can see those pockets located essentially all over the TM, and that is that built up negative pressure that's causing retraction of the TM into the middle ear. Also some decreased mobility. So maybe asking the patient to Valsalva when you're performing that otoscopic exam, and the TM won't have that movement as it should. So treatment for eustachian tube dysfunction, dilatory specifically, we can use decongestion, so pseudoephedrine. It's going to decrease that swelling to allow the eustachian tube to properly function. The oxymetazoline, so we can use that, but we want to only for a short course. Because of the way that it works. So it can cause, some people term it as rebound medicamentosa or rhinitis medicamentosa. So that's where what's actually happening, so it's a reverse effect. Oxymetazoline should vasoconstrict the vessels in the ear, but then they start to dilate the vessels in the ear, and it actually worsens the condition. We can use autoinsufflation, so that's just asking the patient to Valsalva, like where they plug their nose and then close their mouth and blow out air. If they do not have an active infection, because we don't want that bacteria to spread within the middle ear, potentially causing acute otitis media or other upper respiratory tract infections. All right, so if eustachian tube dysfunction is caused by allergies, we're still going to use that nasal or oral decongestant. We can progress to intranasal corticosteroid, fluticasone or beclomethasone. And if they're refractory, we might refer them out to ENT, but generally oral decongestant or combination of an oral decongestant and a intranasal steroid will treat eustachian tube dysfunction. Complications, so barotrauma, serous otitis media, which we'll talk about, and a cholesteatoma can develop. I would actually add probably like acute otitis media on here as well. Pressure and build up of fluid. All right, any questions on eustachian tube dysfunction? All right, no questions. All right, so next we'll get into serous otitis media, so also known as otitis media with effusion, secretory otitis media, or non-secretive otitis media. In this class, we'll just refer to it as either serous otitis media or otitis media with effusion. That can be confusing. And then chronic otitis media with effusion is the same as serous otitis media. It's just when the patient has it for longer than 3 months. pathogenesis, so chronic eustachian tube dysfunction, remember we're talking about complications of eustachian tube dysfunction. So that negative pressure builds up within the middle ear, and then fluid is transuded out of the cells and built up in the middle ear. That doesn't necessarily mean that this fluid has like a bacterial infection associated with it. It can be they can develop, or because thinking about like fluid harboring in the middle ear, they can develop a bacterial infection, but don't just assume that the fluid is infected just because it's built up in the middle ear. If persistent, we may want to consider a referral to ENT, or and they would likely correlate with oncology. We wouldn't just refer directly to oncology because the patient may have a nasopharyngeal carcinoma. So what's causing that middle ear buildup is not not necessarily the serous otitis media, but the nasopharyngeal carcinoma. Yes, sir.
So, the fluid transduction is literally just intracellular fluid that is then moving the extracellular space into the actual middle ear of that.
Mm-hmm.
And is it, just try to simplify it around my head around it real quick.
Yeah.
So it's this persistent negative pressure environment that is basically squeezing the cells for lack of a
Mm-hmm.
better term.
That's essentially what you just explained is fluid transudation, where that fluid is being, because the negative pressure is pulling that fluid out of the cells into the middle ear. Yep. So generally, we're gonna see this diagnosis in children because they have that flatter eustachian tube. They might have had a recent acute otitis media infection. We can see it in adults, but generally it's going to be children less than probably 12 years old. Oh, not 12, 9 years old. Symptoms, they can be asymptomatic or just have that sensation of fullness, right? But that doesn't really tell us much, so we have to tie in our HPI, our physical exam to get to this diagnosis. All right, this is just kind of reiterating that children are at a higher risk. They have that shorter eustachian tube, it's more horizontal, it's that elastic cartilage, and typically, or in general, they may have larger adenoids as well. So, and we'll get to a picture here. You can see where these large adenoids, they can obstruct that eustachian tube, preventing that pressure equalization. All right, so that can cause some negative pressure buildup or dysfunction within the eustachian tube to lead to serous otitis media. Some risk factors include family history of acute otitis media, daycare. Children are usually, in daycare or school. Immunodeficiency, smoking, even if it's secondhand smoke. Other risk factors include large adenoids, allergic rhinitis, and some craniofacial abnormalities where their eustachian tube might not be that normal, might not be in this normal anatomy. Physical exam findings, so this is kind of how we can, along with the HPI, differentiate. So that TM, you see how it's kind of discolored, translucent, gray, yellow. When asking the patient to Valsalva, the TM might not move because it'll be hypomobile, secondary to that pressure buildup because the fluid is in the middle ear pressing against the TM. Patients could have some conductive hearing loss. Additional testing, so we can refer them out to audiology to do an audiogram, a tympanogram, which we talked about in our first lecture. All right, treatment, so it'll be decongestants, both oral and intranasal. We can progress them to intranasal corticosteroids, but biggest thing here is no antibiotics. So just because they have fluid buildup in the middle ear doesn't mean that it's infected. Specifically with children as well, so just don't make that assumption. And then when we talk about acute otitis media, you'll kind of see some of the signs and symptoms that are indicative of an infection as opposed to where this patient doesn't present with those signs and symptoms. Their vital signs might be normal as well, so that's something else we can kind of take into account. This is just an example of acute otitis media. virus-free, that fluticasone help treat. And then auto-insufflation, only if we know the patient does not have active infection. Because if the patient has active infection and they auto-insufflate, that bacteria can transfer to other parts of the oral pharynx or even in the lungs, where you guys will talk about that in palm. I think you guys get that in junior, maybe senior, I think junior. Treatment, so if oral or intranasal decongestions do not work, or we've tried intranasal steroids, they do not work, we can refer them out they can have the tympanostomy, so those are the ear tubes. They're gonna serve as that pressure equalizer and help drain that fluid. This is, again, more commonly in kids. They may have the adenoidectomy, so removal of their large adenoids to allow the eustachian tube to function in its proper anatomy. But just remember, biggest thing, if we use the oxymetazoline, no more than 3 to 5 days, because it can cause that rebound medicamentosa. And then if we are going to use long-term, if we're going for like long-term treatment, intranasal steroids, so they do take about 2 weeks to become effective. So it's just educating the patient that I'm starting you on oral decongestants for short-term relief, and then the intranasal steroids will, because they're the most effective, they'll kick in within 2 weeks. So short-term and long-term use. All right, I think we'll stop there and then we'll pick up tomorrow. Any questions on anything that we covered today?
So for, alright, so for URI, we're making that call just kind of based on
For which slide?
so if you're just going back to the serious offense media, so we're not advising the patient to tell cells that they have a URI.
Mm-hmm.
We're just making that assumption that I call based off of history of illness.
That, and then we'll also talk about upper respiratory tract infections in our next lecture. But yeah, the signs and symptoms that the patient is presenting with in your physical exam. Typically, patients with a URI, they might have like a low-grade fever, right? So yeah.
So like they're not presenting with no history of fever, no kind of irregular or facial lymphatic nodules or anything kind of stages.
Yeah. A URI, yeah. Just so I get clarity on your question, are you asking how the patient present with URI symptoms?
I mean, I guess the heart of my question is just like if we're doing it, if we're trying to make it into your judgment, and
Yeah.
we're having a specialized testing or anything, okay, like a blind review or am I
Yeah.
doing specific testing for that?
Yeah, so I mean, you can do some testing, and we'll talk about it as well, but like generally a patient with a URI, they might have cough, fever, congestion. I would say go more on the precautionary side. If you think that they have a URI, just don't ask them to auto-insufflate and just stop the infection. So that way you prevent the flow of respiratory tract infection. Yeah. All right, any other questions? All right. Oh, really quick, so a couple people asked me, do I do a review, just so you guys know, I should have said this in the beginning, but I'm not gonna do a review. I will provide some practice questions for you all, and I did highlight this in the beginning, so if you see that PANTS blueprint indicator at the bottom of the slide, so that's like the more high yield material that's gonna be testable. Other information, we go over it so you can kind of get a sound knowledge of differential diagnoses within otolaryngology, and then you'll talk about some of that stuff in other classes, but just so you all are tracking and preparing correctly. All right, that's all I have. I'll stay around for a little bit longer if you have any